Okay, hi, welcome everyone to our latest ScHARR mini masterclass. Looks like lots of you haven't responded to the poll yet. There's still time to if you want to. We just wanted to know whether any of you have been to one of these sessions before. Getting lots of responses now. Great, thank you. There's a few of you that have been before. For those of you that haven't, we run these sessions once a month with a range of staff from ScHARR, giving them the opportunity to talk about their research. The way that we run the sessions is that obviously I'll introduce our speakers today. If you've got questions while they're speaking, just put those in the chat box if you can, and I'll give a slide at the moment just to make sure everybody's clear about how to do that. But post questions in the chat box as and when you want to, but we will come to them at the end. So I'll be moderating, I'll be keeping an eye on the questions, and then when we get to the end of the presentation, I'll pose your questions to Fiona and Eleanor. So questions in the chat box if that's okay. Just to explain how Blackboard Collaborate works for those of you that haven't necessarily used it before. Basically, the only thing you really need to know about is the little purple tab, which will probably be in the bottom right-hand corner. Click on that and a menu will open up, which gives you access to the chat box. So where the little speech bubble is, that will appear once you've clicked on the little purple tab. Click on the chat box and then you'll be able to see the chat, so any other questions that have been posted, and you can just type in your questions at the bottom of the chat box and hit return when you're ready to post your question. Sometimes people like to make kind of observations that aren't really questions during the session, and that's fine. But if you have a question, it's really helpful if you can put Q in front of your question so we can sort of clearly identify questions as opposed to just kind of general comments. So before we get going today, I don't think I introduced myself. I'm Claire Beecroft. I'm the Deputy Director of Learning and Teaching in ScHARR, and I'm the moderator for these masterclass sessions. At ScHARR, we run a range of postgraduate programs. We're very much a research-led school, and all our teaching is for postgraduate students, including programs that Fiona teaches on, including our Masters in Public Health program and our range of short courses. The links on these slides, we'll send you the slides and the link to the recording after today's session, but once the presentation begins I will put some of these links in the chat box if anybody needs them. There's the link to our ScHARR Facebook group there as well if you're interested in joining that. So yeah, we have some short courses upcoming as well. We have our Introduction to Using Social Media to Communicate Research Online with Andrew Tattersall, that's next week. And then in the not too distant future, we have our online introduction to Starter, to R, and our course about how to quickly synthesize research. So all of those are coming up relatively soon. And then a bit later in May, we have our program about systematic reviews and meta-analysis, another one of our online short courses. So again, the link for those is there. The next two mini masterclasses coming up after this one are in May. Dr. Sam Caton will be talking about promoting vegetable intake in preschool children. And in June, Dr. Emily Wood will be talking about supporting a mentally healthy NHS workforce. And again, I will put the link to all of these in the chat. So today we're joined by Dr. Fiona Campbell and Eleanor Sheldon. They will be talking about the factors associated with student mental health, reviewing the evidence. Just to introduce our two speakers with a bit more background detail. Fiona is a research fellow in health economics and decision science section at ScHARR, and her background is in clinical nursing, specifically oncology nursing, district nursing and health visiting. And she's worked in both the UK and developing countries. She's trained in systematic review methodology and as well as conducting and publishing reviews for NICE, for the UK Health Technology Assessment Programme and for the Cochrane Collaboration. She also does methodological work developing systematic reviewing methods and techniques, and she teaches on several of ScHARR's programmes, again with her teaching being focused on teaching systematic review methodology. Eleanor joined the Clinical Trials Research Unit in July 2019 as a research assistant, but prior to that she was a paediatric research assistant at the Clinical Research Facility at Sheffield Children's Hospital, and prior to that a research assistant in the Psychology Department at University of Durham, where she completed her first degree in psychology. I think that will do as a bit of an introduction to our speakers. Sorry, Fiona, I called you doctor when I shouldn't have. I apologise for that. I always get carried away. So at this point, I'll hand over. I'm just going to switch the slides over to Fiona and Eleanor's slide presentation, which you should be able to see any second now. Okay, so over to you, Eleanor and Fiona.
Thank you so much, Claire, and thank you, Andy and Claire, for organising these, Andy for all the publicity around it. It's been great. So welcome everybody to this session. Today, Eleanor and I are going to be presenting the findings from two different systematic reviews. But both reviews addressing the same question, which is what are the factors associated with student mental health. So I'm going to start, and Eleanor will be quickly following on, and she's going to describe her findings first. I will then describe my findings, and then Eleanor will look at some of the limitations of our approaches and ways forward, and at the end of that there will be an opportunity for asking questions. So I'm sure that all of you will be aware that the problem of poor mental health amongst students really has hit the headlines. There's a growing crisis, and it's a public health priority. If it's information or a new survey that's just highlighting the scale of the problem, or a tragic suicide, we seem to be frequently seeing these headlines in our media. But what about behind the headlines? Is there a problem, and what is the scale of the problem? Well, we do know that students are in a vulnerable age group, that many mental illnesses, including depression, anxiety, eating disorders, substance abuse disorders and psychosis first appear before the age of 24. And we also know that starting university or higher education is a period of time which is characterised by large changes in the social environment that are usually adaptive and positive, but which alternatively can be difficult, stressful or aversive. So young people are moving away from home, they're developing new networks, new identities with more independence and accompanying responsibilities, new intellectual demands and ways of learning. But we do know that even though student numbers have remained much the same over the last 10 years, that there has been a huge increase in the number of students who are disclosing mental health conditions. We know from a recent large survey that 1 in 5 students is reporting that they have a mental health diagnosis. And we also know from some of those headlines that during the lockdown there has been a huge increase in the number of students who are describing having mental health difficulties. There's also been an increase in the suicide rates among students. And we know that these have long-term implications, not just for the individuals, but that there is implications in terms of poor academic achievement. Students are more likely to drop out. There's huge financial consequences for them, for universities, for society as a whole, and the need to think about appropriate resources. But critically, one of the reasons that we undertook this work is because actually, in terms of thinking about preventative strategies and going upstream to understand why actually are these problems arising and what sort of appropriate prevention strategies can be designed. So Eleanor, over to you.
Hi everyone, thanks Fiona. So as I'm sure you know, mental health is a very broad term, and it can encompass lots of different types of disorders and problems that are associated with cognition, behaviours and emotional well-being. And when it comes to the student population, there are different ways that clinicians and healthcare workers in university settings and researchers can go about determining whether or not a student has a mental health problem, and if so, whether they're experiencing a different type of mental health disorder like depression or anxiety, or whether it's just generally low well-being. So we have the Diagnostic and Statistical Manual of Mental Disorders, which is known as the DSM-5, and that's a standard classification system that's used to diagnose mental health problems generally in clinical settings. This can be used to diagnose students with mental health problems, but it's not generally used in research and might often be inappropriate, as students may not reach the clinical threshold for a mental health disorder but nonetheless are struggling with their well-being. And so more commonly in research, mental health is measured using self-reported outcome measures, so like the Beck Depression Inventory as a measure of depression. And these are validated tools that are considered to be reasonably reliable in the results that they produce. Though again, there is the caveat that they were developed with clinical populations, and again might not be appropriate for students with low levels of risk, but I'll go into that in a bit more detail later. And then again, from measuring suicide, there are different approaches. So there are risk assessment tools to determine different levels of risk that students might present, or of self-harm or committing suicide. And then, for example, in my review, there were case control design studies which take a more retrospective approach and look at suicide statistics over an academic year or a period of time, or for example, the number of students who have self-harmed, and then analysing the case notes of those students. So lots of different ways to measure mental health. Okay, so I'm now going to talk a little bit about the systematic review that I did with the help of some colleagues in the psychology department who I've seen are on the call. So hi, Mel and Claire. I'm going to talk about how I approached reviewing the evidence, specifically for the prevalence and risk factors for mental health problems in student populations. And then Fiona is going to talk a bit about her approach because we, as she said earlier, we approached the topic from different angles. So there's been lots of different research into the prevalence of student mental health and how it's becoming more and more of a problem. And there's also been lots of research into the risk factors, explaining why some students are more at risk than others of developing a mental health problem at university. But when I started looking into this a few years ago, I realised that there was no published review providing an overview of this research or the quality of it. So I decided to have a stab at it by undertaking this review and trying to synthesise that evidence and come up with a set of discrete risk factors for this population. So how did we go about it? We conducted searches on Medline, PsycInfo and Embase, and that generated 3,614 articles of screening, so quite a decent chunk. And to be included in the review, participants needed to be undergraduate students with at least one mental health outcome as a primary endpoint measure. The design for the studies were longitudinal observational cohort designs or case control designs, and we decided to exclude cross-sectional designs because we thought about the difficulty of determining cause and effect relationships between the risk factor and the mental health outcome. We used the QUIPS tool to assess the methodological quality of the studies, and then for the data synthesis, we initially approached this using a narrative synthesis, a risk categorization protocol by Ferber et al., which I'll explain a little bit later. And then as we were going through the data, we realised we could do a post hoc meta-analysis to estimate the pooled prevalence of depression and suicide outcomes and the associated risk factors. And the outcomes that were looked at for that meta-analysis were chosen simply because we had enough studies that met the eligibility criteria for doing a statistical synthesis. So what did we find? 8 studies were entered into the meta-analysis for depression prevalence, and that was estimated at 25%. The pooled prevalence of suicide-related outcomes was based on 4 studies at 14%, and the rates that are presented in the review are similar to those reported in the literature. So, for example, the World Health Organization conducted a survey in 2016, and they found out of 1,572 college students surveyed, 20% had a mental health disorder, so not too dissimilar from what we found. And we did find significant heterogeneity, which again is something that I'll discuss later when we talk about the limitations of this research field in general. Okay. For the meta-analysis, we found 38 individual effect sizes were entered, and from that we found 5 significant risk factors for depression and 3 significant risk factors for suicide-related outcomes. Presenting a current mental health problem at baseline, and that generally being in the first year of university, was a risk factor for both outcomes. Parental depression and separation, cognitive response styles, and sexual harassment significantly predicted depression in students, whereas financial difficulties and childhood adversity, which is basically like people who have experienced childhood abuse and maltreatment, abandonment, those sorts of things, that predicted suicide-related outcomes. So there were 13 risk factors across depression and suicide. So for the narrative synthesis, we looked at 66 articles in total. 64 of those were longitudinal and 2 were case-control designs. As you can see from the slide, there were lots and lots of different risk factors, which I won't have time to go into detail today. But essentially we use this categorization system which breaks the risk factors down into primary categories and then into secondary level categories. So for example, we have relational risk factors, and that can be broken down into things like poor social support, loneliness and social isolation, all things like that. But what this slide doesn't really reflect, which is hard to sort of capture, is that all these different risk factors predicted a wide range of different mental health outcomes. So, for example, students who experience negative life events and low social support are at an increased risk of eating disorders like bulimia, whereas loneliness predicted depression, stress and anxiety. Some risk factors can predict several different outcomes, whereas some are more specific, like the one for bulimia. So yeah, it does get quite complicated quite quickly, but we have the main categories there on this slide. So socio-demographic, lifestyle, physical health, psychological, predictors of response to trauma, and then the factors related to higher education, so those that are related to studying at university, like academic stresses and workload, that sort of thing. One way to simplify all of that was to summarise the risk factors by describing them on an individual, interpersonal and systemic level. So individual risk factors include things like the childhood adversity or low self-esteem and are specific to the individual with the presenting problem. Interpersonal risk factors include things like the poor social support, loneliness, the relationship that the student has with their parents, all that kind of thing. Sort of social-based risk factors. And then finally we have those which we call systemic risk factors, so taking a much broader perspective and sort of suggesting that mental health problems can be a byproduct of studying in higher education. So those might include things like the academic pressures, financial stress, experiencing sexual harassment on campus, that sort of thing. So that's how we try to sort of simplify that huge web of different risk factors and the different outcomes that are associated is break down onto those 3 different levels. Okay, now I'm going to hand back over to Fiona, and she's going to take you through how she approached reviewing the evidence. If you have any questions then or about the methodology or the findings of my review, then We'll have that time for that at the end. And just to mention that the review was published recently, so it's available for anyone who wants to read it online.
Thank you, Eleanor. So just to turn to the review that we did, which was which was NIHR funded and done as part of the Public Health Review Team work programme, and just to acknowledge that I was part of a team that Lindsay, Sue, Anna, Chris and Liddy were all involved and supported this work. So we undertook a mixed method systematic review. So we included qualitative studies as well as quantitative studies. We also actually had a narrower focus because we were wanting to apply these findings to a UK context. We only included UK-based studies. And we also limited it to a decade, so studies published between 2010 and 2020. Another way that we differed slightly from the approach that Ellen took is we had a much broader outcome inclusion. So we were interested not just in mental health diagnoses, the ones that reach a threshold for diagnosis, but also indicators of mental distress, but also mental well-being, what factors support positive mental health. And we used appropriate quality assessment tools for those and undertook a narrative and thematic synthesis. So we included 29 quantitative studies. Most of those, we also included cross-sectional studies in that, and most of our studies were cross-sectional with a smaller number of longitudinal studies. We had 7 mixed method studies and 8 qualitative studies. And just to say a little bit about the nature of that evidence and the implications of that, particularly for the generalizability of the findings, that most of the studies recruited their sample just from one university. And I mentioned that we had a large number of cross-sectional studies, and there are limitations with that, as Eleanor mentioned earlier. The sample also was there were more women in that sample. Ethnicity and minority groups were poorly reported and formed a small part of the populations when it was reported. And it was also, the sample wasn't representative across subjects. So for example, in 5 of the studies, they only recruited students from the psychology department. So those may be factors that would influence the applicability of the findings. Now, Eleanor mentioned the challenges of how to sort of group and make sense of these factors, and it was the same, and we struggled with the same challenge. There were 63 different factors that we identified, and those included sort of a wide range, things like age, different psychological characteristics, stress, health behaviours, and so on. And in order to try and conceptualise them and make sense of it, we grouped them in the following ways. So factors that we described as vulnerabilities, things that are not readily modifiable, factors that can be considered triggers that would contribute to poor mental health, factors that we described as buffers that would promote mental well-being and prevent poor mental health, and those that are red flags associated behaviours with poor mental health. And in terms of the outcomes that we considered, we were fairly broad, like I mentioned, and most of these outcomes were using validated self-reported questionnaires. For example, the satisfaction with life scale, the Beck's depression inventory, and so on. So a wide range of factors with a wide range of outcomes, and that really prevented any kind of meta-analysis of this data. I'm putting this slide up not because I expect you to try and understand the small text on it, but really just to illustrate some of the ways that we try to grapple with this data. So, for example, these are just the psychological variables where we tried to sort of understand and look for patterns in the data in terms of the strength of the correlation and in whether the relationship was positive or negative. So these kind of complex diagrams to try and visualize and look for patterns across our data. And what I'm going to be just showing you now are those factors that we found that were most consistent across the studies and showed the strongest correlations. And you'll see the overlaps that with Eleanor's findings too. So those vulnerabilities, those factors that increase the risk of students experiencing poor mental health, they begin at a young age before a person enters university. And as Eleanor found, we found that those children, young people who've got traumatic experiences in childhood, of experience of use, are strongly, the relationship with poor mental health, self-harm, suicidal behaviours, anxiety, depression and paranoia was one of the strongest findings. Also, students who self-identify as LGBTQ, also at higher risk of poor mental health. Likewise, students who have autism and those with a history of mental illness and a family history of mental illness, also more at risk of developing poor mental health at university. Those factors that we describe as triggers, perhaps the most striking were those of loneliness and isolation, where the correlation was very strong. Also, stress, body image concerns, how somebody sees themselves, how they feel about that, also was associated with poor mental health. Those factors which were most strongly associated with mental well-being and protective of mental health were a sense of belonging. A sense of belonging was central to positive experiences and was strongly linked to the experience of transition during the first year. And then some of these other characteristics, sort of psychological characteristics or strengths, self-esteem, how you accept yourself, how you feel about yourself, adaptability, the ability to adjust and adapt to new circumstances, resilience, the ability to recover from adversity, to react adaptively to situations, optimism, positive outcome expectations. All of those characteristics were positively associated with mental well-being. Also, engagement in physical activity, and there were very few variables, factors that looked at university practices, but this one, a good induction program, actually seemed to be, was associated with mental well-being and made a difference. Some of the red flags, those behaviours that were associated with poor mental health, were lack of engagement, and that was lack of engagement across a wide range of learning activities, not just sort of turning up to teaching, but engaging with tutors, accessing online materials, going to the library, so engagement across a wide range of activities. Poor mental health was also associated with unhealthy lifestyle behaviours and a lack of help seeking. The study designs that we included were not ones that prove causality. And in fact, in many ways, they really simplify things, but they only really show associations. So it's perfectly possible that factors can be associated with an outcome, but that it's not causal. So for example, loneliness may be strongly associated with poor mental health, and it is, but that's not because it causes it, but because it's a consequence of behaviours that result from poor mental health, or it may be, for example, a perception of being alone. And causality itself is a difficult term with different meanings. So there's a problem with the way that we were looking at this, and we've been looking at this in the literature and presenting it, and it suggests a linearity that's not really true, that factor plus student equals poor mental health, or factor plus student equals mental well-being. It may be that the factor only becomes important in its contribution to poor mental health when it's combined, say, with other factors, or when it's in of a sufficient duration or sufficient size. And its absence may still lead to poor mental health. And it may be that it's a different set of factors. We're not going to find one factor that will solve the problem. And the reality is that poor mental health and mental well-being are the result of multiple interrelating factors at levels way beyond the individual that are going to be social, cultural, political. So in an attempt to sort of address this problem and this limitation of this sort of linearity that we were looking at, we really tried to explore the data a bit more using some of the qualitative findings, and to try to think about the mechanisms behind some of these factors and how they might interrelate. And this again is a diagram that Lindsay put together from her analysis of the qualitative studies that tries just to illustrate these complex linkages. So we're not talking about factor outcomes, that they all are all connected in complex ways. And we tried to kind of demonstrate that and explore it in sort of diagrammatic ways. I'm just going to talk you through this particular diagram, which shows how some of these factors might work, and these sort of positive and negative feedback loops that seem to emerge from the data. So I'm just going to... So when we look at when students arrive at university and this sort of transition period that they go through, students might arrive with greater social capital, the ability to draw on resources accumulated through social relationships, and the ability to learn from those, and they may come at different places, and during transition, those with perhaps greater social capital are able to make friends, plug into social networks, gain support, and to start flourishing, gain confidence, make more friends, and develop and have reinforcing social networks where mental well-being is strengthened. One of the negative feedback loops is potentially where students during transition aren't able to join those social networks. They become lonely, isolated. That can lead to a sort of negative spiral. So we're seeing these sort of reinforcing negative and positive feedback loops. Just want to say a little bit about the adolescent brain, and to draw on work from social neurocognitive science. And work in this area has really just highlighted what is a change in thinking around the adolescent brain and around the way that the adolescent brain develops, and adolescence through to early adulthood. And it's really challenged the idea that the neural development happens all in early childhood and doesn't go on and extend through adolescence and into early adulthood. But actually that's a period of time, and these studies have drawn on behavioural studies, but also on MRI scans. And they've really illustrated and shown that there are continuing neural developments that go on through adolescence and into early adulthood. And that adolescence represents a period of significant social development, and that this has real implications for education and social policy, and that some of these aspects of brain development really help to explain certain behaviours that are very common in adolescence and a feature of adolescence. And one of those is their susceptibility to peer influence and sensitivity to peer rejection. the need for peer approval is great, and the impact of ostracism on mood is probably higher during this period of our lives than at any other time. And it might help to explain perhaps why older students appear to suffer from less mental health problems than younger students. And it also might explain why lockdown and the measures to contain the coronavirus and the social isolation that it's required has been so devastating for this age group, because the need for contact and social networks is probably at its lifetime peak. Just wanted also to explore these other important sort of cycles and how these factors might interrelate, and this is to do with sort of help seeking, which again was associated, or lack of help seeking, with poor mental health. And that actually there are some factors, so this characteristic of self-compassion, where reduced social comparison, promoting self-acceptance and recognition that discomfort is an inevitable human experience, and how some of these characteristics are helpful in terms of breaking what might be just a negative again cycle, where mental health symptoms are associated with shame and isolation, and the cycle goes on. But some of these factors perhaps were significant because they were involved with actually breaking that cycle. Again, just another illustration of trying to explore how these factors might be interrelated in different ways. So engagement with learning with learning activities was strongly and positively associated with characteristics of adaptability, the ability to cognitively and behaviourally adapt emotionally. And that was also positively associated positive engagement with well-being. So we sort of saw these characteristics both linked to positive engagement, and it really sort of helped us think about in terms of ways forward and ways that that systems can be put in place to better support students, identifying students where engagement begins to wane, and where there isn't a positive engagement might be points of potential intervention. I mentioned that we included in this review a public advisory group, and we invited them to comment on the findings and the factors, and to identify where there were gaps in what we'd identified. So, for example, and these are some of the things that they contributed. One of them was low morale for BAME groups. And this comment from one of our group: all the cleaners were black and the lecturers were white. A lack of help with learning basic life skills, for example, how to write essays and access research. Some teaching models made it difficult to integrate. Having to take responsibility for your own health, the peer pressure to say, it's amazing, I'm having a great time, the expectation that university should be one of the best times in your life, and actually what to do when it isn't. Health and wellbeing services that are hard to see or hard to access or just unhelpful. And also competitive toxic environments. So those were all things that our PPI group, which was made up of students, parents, and student representatives. So I mentioned right at the beginning that one of the reasons that we undertook this work was because we were interested in identifying what would be potential areas for development, what would be some of the upstream approaches that could be done to try and address this problem. And these are just some of the areas, and you can see more of these discussed more fully in our report, which is currently available on the Public Health Review team website. So one of these was actually looking at how we prepare young people for transition to university, how we address expectations, how do we support schools and parents in preparing young people. Are there ways of identifying vulnerability? We've already, both Anna and I both identified those students who may have existing vulnerability. And how do we provide non-stigmatizing support? Also, how can universities work on creating environments that support social cohesion, given the importance of a sense of belonging of those social networks? What can be done to create physical and social environments to promote those kind of networks? Ellen, over to you.
Thanks, Fiona. So one of the things that we noticed when we were going through the data from our review is that the terminology used to describe both risk factors and mental health outcomes hugely varies. So more often than not, papers will use very generic terms like mental health issues, mental health problems, mental health difficulties, and so on. And they don't really provide a definition or an explanation as to what they really mean by that, whether it's something clinical or just general mental health problems. So this made combining the data and understanding it on a narrative and a statistical level very, very difficult, and it's made even more complicated by the large heterogeneity found across the data sets. So that being in the variation in quality across the studies, the length of follow-ups. So some studies would just follow up students for one academic year, some for the whole 3 years, and how the findings are reported, and how mental health is measured. And as I mentioned before, a lot of the inventories that are used in mental health research for students were developed on clinical populations, and so they might not be appropriate for measuring mental health outcomes in students. So just as an example, the GAD-7, which was is a measure used to look at generalized anxiety disorder, was designed for measuring generalized anxiety in patients presenting in a clinical setting, whereas students with anxiety might present symptoms that are specific to the context of being at university, so things like that transition to university from school, socializing with new people who you haven't met before, moving to a new city, or having exams for the first time in higher education. So those kinds of measures might not pick up on those experiences and might not therefore be a reflection of how a student is experiencing anxiety. And because of this poor consistency across the research, it really limits the extent to which we're able to synthesize those data sets. Fiona's gone through the way that her team approached that, and as I mentioned earlier, we used a sort of categorization system for risk factors in mental health, but again, that wasn't developed for students, so there are definite limitations to the research. And let's go on to the next slide because this links into that point. So yeah, on a final note, we just sort of want to say that whilst our findings are helpful for schools and universities and policymakers to identify groups of individuals who are studying at university with poor mental health, and that really is essential for allocating resources and targeting effective preventative care. We really want the take-home message to emphasise that by understanding which students are more at risk, we can start to prevent the emergence of mental health crises prior to or during that transition to university, before they end up, NHS services in A&E, or being referred to the psychology or mental health services at the universities, or going to their GP with symptoms of depression. So it's really about preventing that prior to or during that transition, and then developing interventions that are targeted more effectively at student populations that are more appropriate to their presenting problems. That's not to say that we've got the problem sussed and that we don't have more questions that need answering. So in my paper, we make recommendations for future research to improve the consistency and quality across longitudinal research in this area, and to develop a more coherent and appropriate study design and outcome measurement approaches. Again, not specific to the studies that we found, there are a lot of small scale studies that really need conducting larger scale studies to robustly test the findings. So, for example, studies that looked at low emotional resilience and negative coping, we only had a couple of studies in our review looking at that, and they were quite small scale. So, we recommend that more research is needed to look into those more robustly. And then finally, just to say, the MRC published a progress initiative which recommends that once you've identified a set of prognostic factors for a certain outcome, the next step is to develop and validate a prognostic factor model, so providing a statistical approach to predicting risk in a student population. So if you have a student who meets a certain level of risk, you can have a model that predicts what their likelihood is of presenting a mental health problem further down the line, or having a current one become exacerbated by the university experience. So yeah, those are some ideas for the next steps and a way forward in this research field. So me and Fiona and other researchers have our work cut out for us, that's for sure. But yeah, we have made a small step of progress by doing these reviews. Yeah, so has anyone got any questions? I've seen some in the chat. Yeah, and thank you for listening to us go on about student mental health for 45 minutes.
Okay,
thanks.
Thanks, Eleanor, and thanks, Fiona. So yeah, I'll read through some of the questions because we've already had a few popping up in the chat during the session. So first of all, Saffron asks, when talking about predictions from students with trauma, there is negative life events. Does that mean that those who've undergone trauma are more likely to have these? If so, what negative life events are included in this?
I'm happy to take that question. So as I sort of touched on when talking about the limitations, a lot of generic terminology is used in a lot of the papers, and they don't necessarily go into what negative life events. Specifically, I think that refers to things like bullying, or if your parents get divorced or something like that. It can be quite traumatic, but it's also different to childhood adversity, which is more about having emotional abuse and punishment and domestic abuse and being exposed to that. So it is different to experiencing trauma, because the negative life event might not necessarily be traumatic, but it is sort of to do with development as well. And in terms of what outcomes are associated with, I don't have the list in front of me, but I could get back to you on that one if you wanted me to.
Okay, thanks, Eleanor. There was a question from Mel. She asked, why did you choose to exclude postgraduate students? Now, a participant, Amy, did respond to that, saying that from her experience as someone working in postgraduate mental health, she said there's large gaps in the literature because lots of individual studies exclude PGs, meaning that systematic reviews can't explore postgraduate experiences. Was that the case? Was that the reason why you excluded postgraduate students?
Yeah, I think this is a very specific set of risk factors for undergraduate students, and there will be some overlap, especially with the factors that are related to studying in higher education, like academic workload and exam stress. But I think there's a definite set of risk factors that are associated with that transition to university, and also undergraduates fall into that age category of, generally speaking, being in the younger age groups and sort of moving away from home for the first time to a new city, living on their own, meeting new people, and with that comes challenges which may be positive, and they might have a great experience or they might not, and that might be different to a postgraduate researcher or a master's student who's already been through that experience once.
Okay, thanks for that. And then Amy also asks, how, if at all, did you unpack studies focusing on mental health versus well-being versus a diagnosed condition?
Is that a question for me or for you? Does it say?
No, it doesn't say. I guess either of you, if you feel you're able to respond. I guess it's that idea of how you sort of sift and differentiate and categorize the studies.
I'll have a go at answering, and then Fiona, if you want to add on. In the review that we did, most of the outcomes were measured using the validated tools, and usually they're designed to measure a specific type of mental health disorder or type of mental health problem. So, for example, the Beck Depression Inventory is designed to measure depression. But it was extremely difficult when we had outcome measures that were looking at several different outcomes. So, for example, there's the DAS-21, which looks at depression, anxiety and stress. And you really had to look at the results of those papers to see where certain items of that questionnaire that were looking at depression, anxiety or stress, what they were correlated with. But yeah, it is very complicated.
I would echo that, and in many ways this was quite a new experience. So normally we're looking at intervention effectiveness. So to adopt an approach where we're going upstream, if you like, to understand causal factors was methodologically a lot more complex. And one of the reasons it's complex is because you have these multiple factors measured against multiple different outcomes. And to try and unscramble that and to try and have, know which of those outcomes you can pool and which you can't was quite difficult. So we tried to sort of just differentiate between poor mental health and mental well-being, and then within the text itself we've identified which measures, but it is really, really difficult to know sort of which level of abstraction to pitch it in order to make something useful. And I think just going back as well to the comment around childhood adversity and the strong link that was found in both reviews between that and adverse mental health at university. I think that's really interesting because it's very hard to understand exactly what the mechanisms of that are, and in sort of trying to understand the mechanisms, for example, is the link with the belonging? Is there something about that sense of being removed then from the security you do have to go into a new environment and then finding that you just don't feel you belong? Is that possibly the mechanism? Because one of the mechanisms they tried to explore was coping, and they didn't find a strong relationship with that. So, a lot of these relationships, there's a lot more work that needs to be done in trying to better understand the mechanisms. Why is it that these factors are impacting mental health at university?
Okay, thanks, Fiona. There's a question from Phillips who asks, considering the increase in mental health disorders, have there been studies that have identified the role that a lack of family bond plays in mental health? And then he also asked a sub-question, which I think is sort of asking about, are there any studies, or is there a lack of studies that look at the role of religious bodies association in alleviating mental health? I think possibly he means, I guess, Phillips, you might want to clarify in the chat, but do you mean the role that having a sort of an association with a religious organisation or a faith plays in whether you do or don't develop a mental health disorder, or do you mean the roles of religious bodies in being sort of actively engaging with trying to support students with mental health disorders? I think maybe if you could clarify in the chat, that would be good.
In terms of the research on the parent-child bond, we did have some risk factors in our review that looked at attachment to parents and parenting, and just quickly pulled it up. The factors that we found were having a negative relationship with the mother, and behavioural restrictions increased by the father, negative mood by the mother and father, and also parental depression and a positive family history of parental psychopathology were all linked to various different outcomes for students in mental health. And as for the religious side, I think that would be more a question for Fiona. We didn't have any risk factors related to that, and I would imagine it might be a protective factor if we're coming at it from that angle.
Yeah, so the ones that we've highlighted today are those where the relationship was, where the association was strongest and most consistent. So if it didn't appear, it wasn't because they're not there. It's just because the association wasn't perhaps very strong or not consistent. In terms of parenting, there was evidence around sort of overbearing parenting styles and over controlling parenting styles. And there were weak associations there with mental health at university, and there was one study. There is one study, UK-based study, that's looked at the, and it would link as well sort of belonging, but religious groups and religious faith and its impact on well-being. And yes, it's protective, but there wasn't much evidence for it. It's okay. Lots of evidence doesn't mean lack of effect here. It's usually because it's not been researched by many studies or just been looked at in one small study.
Okay, thanks, Fiona. Lucy says, although it makes sense to exclude studies from other countries and only include the UK, I'm aware research regarding mental health can often draw on findings from studies conducted within the US, Canada or Australia. I'm wondering if there were any factors that led to your inclusion-exclusion criteria regarding country.
Okay, because Eleanor didn't and we did. So yeah, so the reasons for our decision were influenced partly because of the target of our review. So it really was to inform practice in the UK, and of course there are certain policy factors that meant that we had to be careful about using evidence from other settings and applying it. So sort of, for example, widening access, student fees, we felt were potentially important contextual factors. So that was one of the reasons. So for it. And also there was a very pragmatic reason. We didn't have long to do this review. We had to do it quite quickly. So we had to make sensible decisions around what limitations do we impose in order to make it achievable. And so that was one of the, so there were two reasons really why we made that decision. But we do recognise that that you possibly lose something in doing that.
Okay, just to add on, just to add on from that, when I approached sort of doing the protocol for this review, my sort of goal was to come up with a set of risk factors that was comprehensive and was applicable not just in the UK but on an international basis. The idea that you can learn lessons from, you know, what risk factors might come up in other places, and if you were going to come up with a targeted intervention or preventative care, then, you know, with that understanding that there are other risk factors that are prevalent elsewhere for international students, for example, it might be applicable. But yeah, there are pros and cons to the different approaches that we've taken. But I think it's a good thing that we both didn't do the exact same thing, otherwise, yeah, we'd have the same review.
Okay, I think we've got time very quickly for one last question. So Louise has asked, what is your view on the rise of phone apps appearing and meant to support or enhance your mental health? Are they a valuable self-help tool for students, or could this bring even more confusion to the student?
That's an area I'm not so familiar on, because I think that's more to do with, you know, if we've done a systematic review on what interventions are available and how effective they are. But one thing I could say is that one of the risk factors we'd found across 2 different studies was that excessive mobile phone use and problematic mobile phone use were both risk factors for depression and anxiety. So yeah, but I guess it depends on how you're using your phone. But if you're going to try and, you know, reduce those outcomes, then maybe encouraging more phone time for students with that risk factor might not be the best approach. But I'm not an expert, so happy to be contradicted.
Okay, I think we're going to have to bring the session to a close there, because we're at 2 o'clock. But thanks everyone for joining us today. There's been lots of chat going on in the chat, as well as those questions, which is really nice. And a few people have shared some links to things like I think there was a link to the SMART network, the Student Mental Health Research Network. Amy's posted a link to that might be useful to some people, and it sounds like a few people making some connections in terms of research in this area as well, which is really, really good to see. So thanks everyone for joining us today. I did earlier on in the chat post the links to the next two that are coming up by Dr. Sam Catton and Dr. Emily Wood, so do sign up and join us for those if you can, and we will send you the link to the recording of the session today as well, which you will be able to see the chat in that, so if you do want to follow up any of the links later on through the recording, you will be able to do that. But thanks everyone for joining us, and thanks very, very much to Fiona and Eleanor for agreeing to do this presentation on obviously a really, really interesting and really important topic at the moment. So thanks everyone.